Good morning, everybody. And I want to invite you to a little short meeting with Dr. Tejaswini Kulkarni, Assistant Professor of Pulmonology and Allergy and Critical Care Medicine, Director of Interstitial Lung Disease Program at the University of Alabama in Birmingham. Dr. Kulkarni is going to give us some takeaways from the important chest conference that was held this year, 2022, in Nashville. And it's such a prestigious conference that we really appreciate what she has to say about some takeaways for people with pulmonary fibrosis. And Dr. Kulkarni, the meeting is now yours.
Thank you for the kind introduction. I'm excited to be here again and talk to you about what we learned at CHEST. CHEST is an international conference attended by several thousand pulmonologists and critical care physicians across mostly US, Canada, but also across the world. And we had a fantastic conference from the pulmonary fibrosis viewpoint, or all of us physicians who have dedicated our time and energy to try to help all our patients with pulmonary fibrosis. This was a very fruitful meeting. We had several sessions that were focused on discussions of our patients with pulmonary fibrosis. What can we do? What should we be doing to help our patients and such? So just to kind of talk about each area that we discussed, I want to start with a session that was on interstitial lung abnormalities, which is like the earliest spectrum that we think as we think about pulmonary fibrosis. So interstitial lung abnormalities are typically they're common incidental findings on CT scan. The patient gets a CT scan done for suspicion of lung cancer, or they had a CT of the abdomen and saw parts of the lung and there were some abnormalities there. And these, in about half the patients that we see interstitial lung abnormalities, it progresses over, if you follow them for over a 5-year period of time. And there was a lot of discussion around that. So how do we truly define interstitial lung abnormalities? They're basically, there's presence of fibrosis, which is really mild, it's subtle, it's, in maybe about like less than 5% of the lungs are involved. The distribution is very variable, as we talk about the patterns on CT scans, but the presence of these abnormalities, there's been a lot of research lately on this, and we are trying to understand how do we identify this early on, and then what do we do with this finding? Not everybody progresses, but which patients should we follow regularly, and when do we truly call this as not just interstitial lung abnormalities, but now pulmonary fibrosis, and start thinking about treatment? So we had a lot of discussion on interstitial lung abnormalities. And then so switching gear from that, then, we talked, there were sessions that were focused on early diagnosis of ILD. How do we, we know that there are delays in the diagnosis of ILD from the time that the patient has symptoms to where there's either seen by primary care physicians, to community pulmonologists, to an interstitial lung disease center. There's so many different steps involved in the diagnosis, not just identifying that these symptoms could be related to pulmonary fibrosis, but then also being able to get pulmonary function tests, to get CT scans, get over the hurdle of insurance issues, and actually get that scan done in the right pattern that we wanted to identify interstitial lung diseases, to getting the final diagnosis of an ILD and starting therapy. So we had sessions that focused on early diagnosis, and I think we've talked about this before, but like we had a session to talk about how the bridging specialties, that is a That is a initiative that was between CHEST and Three Lakes Foundation. And what have we done as a steering committee? There's a new toolkit that's now available on the website for primary care physicians as well as pulmonologists to be able to learn about pulmonary fibrosis and how do you approach this patient and what are the steps in terms of like the early diagnosis. And that toolkit was launched recently, and we talked about that at the session. We also had sessions on, one session that I chaired was the mock multidisciplinary discussion. It's not easy for community pulmonologists to have access to a multidisciplinary discussion, but the academic centers have that advantage. And so we were a group of 3 pulmonologists, Dr. Dilling, Dr. Scholand, myself, and we had our pathologist, Dr. Gonzalez, and we had Mr. Stevens, our radiologist, and we went through a couple cases on how do we do this in real life. We have a patient who comes in, what workup do we do? What questions do we ask about exposures, genetics, family history? How do we look at the CT scans? How do we understand these patterns? What is the pathology? Does this patient need a biopsy? So these were all the questions that we discussed through like an actual real life case patient that I'd seen in our clinic. And so it was a very exciting session to do. And there were similar such other sessions which were done differently, but basically trying to teach the algorithm of ILD diagnosis. So from there, now once you have your diagnosis of ILD and well, you have IPF, what next? And so we learned about how to manage patients with IPF. It's not just about the antifibrotic therapies. I mean, yes, that is very important. Starting the earlier we start therapy, the more benefit we're likely to get, but also a comprehensive management of our patients, not just antifibrotic therapy, but cardiopulmonary rehab therapy, oxygen therapy, comorbidities, looking for comorbidities like reflux and pulmonary hypertension and treatment for those. So we had a lot of discussions around that. For patients who are diagnosed with connective tissue disease related ILD, there was a great session that essentially discussed which patients should be started with which immunosuppression medications, and then what is the spectrum? How do you escalate the immunosuppression medications? And then from there to when do you start antifibrotic therapies in these patients? And so there was a great session on that. And then finally, we had another session on progressive pulmonary fibrosis. Now, if you're there, there were recent guidelines published in May, which talked about progressive pulmonary fibrosis as an entity. Now, it's not a diagnosis, but it is, when disease progression is seen in any type of pulmonary fibrosis other than idiopathic pulmonary fibrosis, that is called progressive pulmonary fibrosis. Essentially, how we define that is based on lung function. If there is greater than 5% decline in FVC over a 1-year period, or a greater than 10% decline in DLCO, of course, there's increase in symptoms, or there is changes seen on CT scans. These are all factors that we look at when we talk about progressive pulmonary fibrosis. So there were sessions that were focused on that. How do we identify our patients? How do we decide early on? How often are we monitoring our patients? So probably 4 to 6 months is ideal. But we also need to understand the risk factors, which of my patients may actually have a higher tendency to progress. Do I have to see them much quicker than 6 months, so I can catch this fibrosis, the progression early on. So there's a lot of discussion around these new guidelines and how we apply that to clinical practice. And then what? Now you say your patient has progressive pulmonary fibrosis. How do you treat these patients? Now that's still a gray area. There's a lot of unknowns in that, in treatment of progressive pulmonary fibrosis. But it was robust discussion, hearing from everybody about how they would approach a particular patient who's progressing versus what another pulmonologist's opinion is. And I think it was really good to hear that, because that is still an area where we as ILD specialists can really research more, try to understand more, and identify these gaps. And so there's discussion whether you use more immunosuppression or do we do antifibrotic therapy, a combination thereof. I mean, we have to understand that yes, the combination, that sounds great, right? But all these medications have side effects. And a lot of our patients are older, they have other comorbidities. There's other medications that all of you are taking. There's high pill burden. So how do you balance all that? I think that's something that's really important. And so we sort of had some discussions around that. So, that's essentially, it was a wholesome discussion at CHEST from early interstitial lung abnormalities to coming to a diagnosis of interstitial lung disease, whichever type that is, to treatment, management, and to when there's disease progression. And then there were sessions on lung transplantation where you've done everything you had from in this spectrum, right? And then what's left is my patient eligible for a lung transplant? Is that the best next step to do? So there were discussions around that, around lung transplant, who is the best, where do we have the highest likelihood of getting success from a lung transplant? I mean, it's not an easy surgery to go through, even after like all the processes that are involved in getting to a lung transplant. It's not an easy surgery to go through. And the post-transplant recovery, has, you have to think about medications, rehab, and all of those processes involved. And so, identifying the best patient, how do we do that? And how do we do early referral to transplant centers? That was another area of focus. And finally, there was a little bit of discussion on, we've done everything. At some point, we have to understand that we've all done our best. And when do we say, well, we've tried it all and we focus on comfort, and we think about our patient as a whole, not just about like these numbers that we're looking at, the FVC, oxygen, it's beyond that. We have to start thinking about, how can I make sure my patient is not suffering at all? Like, focus on comfort. And so there was some discussions along those lines as well. And so that really rounded up what we did at CHEST for ILD. And now then we're looking towards getting sessions ready for next year at the CHEST 2023. It's in Hawaii. And so we're trying to see what's the best way, what are the new things we need to talk about, and more about clinical trial designs. How do we be more inclusive of our patients in trial designs, and what's next? So that's what we're looking forward to.
Oh my goodness, thank you for this wonderful information. And Hawaii, not a bad place. Maybe the PF Warriors can be a participant with a booth or something like that.
Oh yeah, absolutely love that.
I'm curious with just a couple of questions, and you all covered some very big topics. At these conventions, do you have a lot of PCP or other providers like PAs and nurses that attend as well?
We don't have much PCPs that come in, but there's a lot of attendance from the community pulmonologists, as well as nurse practitioners that are in these practicing groups.
That's great to know, because my husband was seeing an allergist before he got his correct diagnosis. And we thought that one of the nurses and the PA were actually saying, your lungs don't exactly sound like you have allergies, but the PCP was just treating him for allergies. So I'm looking forward to this all coming together like you all have hoped as well. So I want to thank you again for joining us today, and hope you have a wonderful holiday season. Bye-bye for now.